Okay. All right. Put up your hand if you know someone who's had headaches. And put up your hand if you've had headaches yourself. That's pretty much everyone. It's such a common problem. Most people present to a healthcare professional because of head pain. So it's amazing how many people end up on medication and not having anyone address the actual cause. So my qualifications as a chiropractor, and having done undergraduate studies in dietetics and also studies in biochemistry, it's put me in a position where I feel like I've got a pretty good grasp on a lot of lifestyle issues that contribute and cause headaches, as well as migraines. Headaches typically are pain around the nerve, and migraines are only an expression of a headache whereby you might have vascular symptoms. So my background is a Bachelor of Science in Biochemistry and Microbiology, and also a Bachelor of Science in Chiropractic. When I graduated, I started doing a lot of study for headache and migraine centres, and the Victorian government asked us when we started headache.com.au to also be their content partner for Headache and Migraine Online, which was what they were doing at the time. They were constructing their website. So my background is pretty much private practice and headache and migraine treatments. Headache.com.au came into being because I got together with some colleagues and we put together a headache and migraine website which talked about the causes, ear, nose and throat causes, sinus problems, headache and migraines coming from neck problems, dietary issues. We put together quite a comprehensive website, and so the Better Health Channel Victorian Government asked us to be their content partner at the time. Headaches and migraines are usually related because they often have similar causes. People presume that headaches are due to more sinister causes than they usually are. Often people think of headaches as being something catastrophic, something very serious, but more often than not, it's your body's way of telling you that there's irritation. So head pain is your body's way of telling you that there's a problem. Often those problems are lifestyle related, they're musculoskeletal related, they're functional related. So most scans show nothing with x-rays and migraines, yet most people get caught up on what the actual scan may or may not show. People are looking for something serious, but 99% of scans show nothing. A lot of people take medication thinking that that's going to solve the problem, but medication is great at relieving pain. It's great at reducing inflammation. But what if the pain is your body's way of telling you there's a problem? So it's really important to take that pain and say, okay, what's contributing to that pain? Would you ignore a toothache? Would you just medicate a toothache? Probably not. I think we all know that it's important to address our symptoms with medication, but it's also much more important to try and look for the cause of the pain. So the diagnosis with headaches and migraines is mostly to do with the history, because the timing and frequency and severity of those headaches gives us a lot of information about what's contributing. Headaches typically, as I said, they involve nerve irritation. Migraines typically involve nerve irritation with vascular changes. The history can give us information as to what's causing or contributing, the what, how, when they begin, what's the medical history. That provides most of the diagnosis. The examination is really there just to confirm what's going on. The reason I write horses, not zebras, is because people often presume that a headache means something very, very serious. But more often than not, it's your body's way of saying there's irritation, there's a problem. So think of, if you hear horses hooves, think horses, not zebras. The scans, the x-rays and what have you, they're often just to confirm if there's anything serious, but more often than not, they show nothing. the history, as I said, is 95% of the diagnosis. The onset, if it's chronic, greater than 3 months duration. If it's more recent, we might be thinking what's contributing to the recent onset. The timing, whether they're in the mornings or in the afternoons, or if it's on the weekends, or if they're seasonal. These are all important clues as to what's contributing to the headaches. It's really important to look at the timing, the frequency, and how long they last for, and whereabouts in the head the pain is. For example, pain around the eyes might often be eye strain. It could also be referred pain from the back of the neck. Pain around the temple and the jaw is often due to people who grind or who have sinus problems. So the location and when they're beginning, they give us valuable clues, and that's all in the history. The severity is not a good indication of the seriousness. Often people think the more severe the pain, the more catastrophic the problem. But in actual fact, the more severe headaches are usually the benign ones. It's the headaches that are progressively getting worse, may or may not involve nerve-related symptoms. They're the ones that should be investigated with suspicion. But 95% of patients have headaches which are not due to serious causes. So it's really important to look at the pain, the location, the quality, the timing, what aggravates, what relieves, look at the patient's lifestyle, look at their medical history, put it all into context and work out what's contributing to that particular patient's headaches and migraines. Examination should confirm the diagnosis. So the examination can be quite simple. It can be only 2 or 3 neurological orthopedic tests, but then that gives us a label, or a diagnosis is really a label. What matters though is identifying what's contributing to that label. So there are many possibilities, and we have to consider most of, or if not all, the possibilities when we examine and when we take a history from a patient. So I really enjoy trying to work out the puzzle. No one profession has the ability to work out what all the potential causes are, because headaches and migraines transcend professional boundaries. You can have optometry issues, dental issues, you can have ear, nose and throat issues. You can have a lot of different contributing factors, and it's really important to look at the problem and say, okay, does this patient need to be referred? Do they need to be checked by someone else? Is this within my area? And what can I do to help this patient and actually address the causes? The International Headache Society in 2018, they released a document which documents over 200 different types of headache migraine variants. So there's migraine aura, there's complicated migraines, there's cluster headaches, there's trigeminal neuralgia, there's dental headaches, eye strain headaches. There's a gazillion different types of headaches, but we can get caught up in labeling them. But what's important is actually working out what's causing them. The scans that are often done, they show a brain, and more often than not, they show no pathology, and that's of course where we all want our scans to be showing nothing. So it's really important to do the scans if there's a suspicion, but the scans are often done as a matter of procedure, often where there's no clinical indication. So a study out of the US back in 2014 talked about the majority of scans not being necessary, but when they dug a bit deeper, they found out that a lot of the medical experts and specialists who were referring for those scans actually performed those scans because they thought that would put the patient's mind at rest. There's been no good clinical reasoning to take a scan, but they're often done as a matter of procedure, and as I said, it often does put the patient's mind at ease. Multiple triggers is the most common reason for most people's headaches and migraines. You might hear someone say, look, sometimes chocolate causes a migraine, sometimes it happens around my period, sometimes I notice a problem when I'm on the computer for too long, sometimes it's when I skip meals. So it's really important to think about what's going on with this particular patient, what's contributing to their headaches and migraines. More often than not, there's a range of things contributing. And so it's really important to address all of those things simultaneously. One at a time often doesn't cut it. And I've seen many patients who have said to me, Jerome, you know, I went to this person or that person and they helped, but it didn't get rid of my problem. And so the key is working out what that particular patient's recipe is, what's contributing. The nerve supply to the head and neck is it basically the facial, all of the facial region inside the skull, the mucosal membranes, the ear, nose, throat, sinuses, throat, all the nerve endings running from there also plug into a switchboard at the back of the brain, and the same switchboard that the nerves coming from the upper neck plug into. So the neurology overlaps, and often neck problems can be contributing to headaches and migraines, much as sinus, ear, nose and throat issues can contribute to headaches and migraines. So it's important to think of that overlap and say, okay, what in that watershed of nerve supply, what is contributing, what could be contributing to those headaches and migraines? So the neurology makes things a little bit more complex. Patients present with symptoms. And so symptoms are essentially an overload of irritation. So listen to the symptoms. Pain is your body's way of telling there's a problem. So why cover it up with just medication? Of course, we have to rule out pathology, and we have to sometimes do scans and do further tests and refer for specialist opinions. But most headache and migraine cases have like poor function, stiffness, dietary issues, poor blood sugar level regulation, hormonal issues, eye strain, too much sitting on the computer, doing the wrong thing day in, day out. So common in modern day lifestyles. They're the kind of problems that we look for. What I do, I take a history and then I dig a bit deep, and then I dig a bit deeper again. And I try and identify all the triggers. Really important to work out what's contributing to that particular patient's recipe, if you like. Understanding and identifying all those possible triggers. I'm also looking for flags. Is there anything that potentially heralds a warning sign, something that needs further investigation? Addressing the functional issues, neck, jaw, stiffness, tightness in the shoulders, but also looking at dietary issues, lifestyle issues, exercise habits, and referring out where needed. So I might refer for other allied health professionals, people who have stress issues, who have dietary issues and eye strain, etc. So really important to work as part of a group and to keep an open mind as to what other professions might be able to offer assistance.
1 minute, Jerome.
Treatment is a solution. It's not a tablet. So what are the individual's ingredients? I diagnose and prioritise what the key issues are: head, neck, jaw, postures, work-related issues. Treatment, looking at what needs to be done to help the patient with those lifestyle and dietary issues and musculoskeletal problems. I give them advice and I refer out where necessary. Headaches and migraines, if you would like help with finding what your causes are, please take a screenshot of this. You can send an inquiry to me at the info@headache.com.au, or appointments can be made online. If someone you know, but they're not in Melbourne, they'd like a full case review and a report to their doctor, they can make a time to do that with me on the remote patients full case review. Thank you.